I'll take 5 minutes.
Feel free, your job, your call.
So whenever when I try renal artery stenosis in young patients, do you see my screen?
Yes.
Yes. Yeah. See, renal artery stenosis in a elderly patient is atherosclerotic etiology, so it's fine. You have no confusions. But in younger patients or in middle-aged patients, when you see renal artery stenosis, the etiology of renal artery stenosis comes into question, because that will have a say on the treatment modality. I mean, how you treat it also. So this is age is 29-year-old male. Yeah, there's a normal left renal artery. Then yeah, so right renal artery, there is stenosis. I think this is far away from the ostium, and so it should be FMD, right, sir?
Very likely, yes.
Yeah, and for such a
I wouldn't rule out aorta arteritis where I don't as yet see the aorta, though I would have expected it near the ostium if it was aorta arteritis. So FMD stands to be the most likely one. That right. I agree.
Yeah, and such tight stenosis, balloon is just enough, or you would want a stent to be put in?
Well, in the initial stages, I used to do only balloon. Nowadays, I would put in a stent, because if you have to do a repeat procedure also, it becomes easier.
Right, sir. So this actually, I put in a stent, but on the light of my recent experience, so let me go on to next slide. Yeah, so I'll also. So this is a 40-year-old male.
Bala, can I ask you?
Yeah.
What was the other medical background for that patient with renal artery stenosis you showed just now? Nothing else? Smoker, diabetic, atherosclerotic, anything else? No? Nothing else?
He came for hypertension, and I pick up all these cases because I do the Doppler. I found Parvus started pattern, so I took him up for further evaluation. And I mean, these are old cases. I don't really remember. Yeah, so this 40-year-old man had bilateral stenosis. And you see that left side, it is in the nail, in the ostium, osteal stenosis. Whereas on the right side, right side, it was slightly away from the ostium. And this could be both atherosclerotic or FMD, because I have hardly seen the typical bleeding appearance in any of my younger patients with renal artery stenosis. That is why I get this issue of trying to differentiate.
Are they smokers, Paula?
I really not able to tell.
I have seen this also, but if you ask them, a lot of them are tobacco chewers rather than smokers.
Most likely, of course, I have not practiced in India for a long time, but in smokers, you can get proximal vessel disease like aorta and iliacs and SMA. We see in the West, in UK, quite a lot of young smokers in their 30s and 40s and 50s coming with the SMA, celiac, or renal stenosis or occlusion. And it's useful to know what their aorta looks on the CT angiogram, whether there's any soft atheuroma in the aortic wall involving the visceral branches. Do you have any information?
So this man, see, you hardly see any other evidence of atherosclerosis in the aorta or any other vessel, but bilateral renal artery stenosis. But I put in stents on both sides and he's doing well. This is a 20-year-old, 21-year-old female. You see that, see a tight stenosis near the ostium on the left side. And yeah, and on the right side, you see there is stenosis farther away and you see ballooning on the branches. So I was in a fix whether to stent it or just balloon it. What I did was actually left side I stented and right side I put in the balloon and dilated because it was involving both the branches.
Do you do CT angio before you do this case or just go straight for angio?
If the urea creatinine is slightly raised also, I don't do CT angio, I go straight for, if it is even 1.5 or, borderline, I avoid using 100 ml of contrast in CT angio and take them because here diagnostic angiogram will just 10-15 ml of contrast, you'll be able to finish.
I think
because the thing is, see, I'm wary of taking up for angio because if I find a finding, fine. If it is normal, then you feel bad that why you subjected him to angio at all.
The thing is, you'll never know what these patients are suffering from apart from treating the renal artery stenosis if they do not have imaging of the aorta and the branches because that's very crucial. Like, for example, if you don't have raised inflammatory markers or other evidence of aorta arteries, for example, and if you do a CT and find periarterial thickening and aortitis, then you know that you're dealing with aorta arteritis. Same way, if you do a CT angio, because from what I can see with the picture, there is no calcification in the artery, so it may not be atherosclerotic. So if you have a classical bleeding, of course, you can say muscular fibromuscular dysplasia, but if it is a smoking related early onset soft atheuroma in the aortic lumen causing, and it also probably help you to know how they are going to behave if they are smokers and if they have soft early onset atheuroma, they will do very badly if they continue to smoke. So it is useful to get a cross-section imaging with the CT.
Actually, in this case, this girl was a medical student. I was not very sure whether, because if it is fibromuscular, balloon is enough, you don't need stent. But I remember her aorta was slightly, there was some undulations, I mean, raggedness, not exactly aortoarteritis, but there was some tendency. So I thought balloon alone will not help. So left side, I put in a stent and right, it was in the bifurcation, and putting in a stent, you might compromise the other one. Then you may have to dilate it, put in a guide wire into the stent and dilate and all those stuff. So that's what I did in that case, and she's doing well. She came for hypertension.
Okay. The thing is, long term, you don't know if they have aorta arteritis, for example, and if you treat only the renals, you also need to know whether they have need for rheumatology investigation, steroid treatment, or any further follow-up. That information will be lost if you don't do a CT because it is so young.
Yeah. So this is that same girl. So we'll go to the next. Yeah, this is again a young female, came for hypertension. See, left side, nearly osteal stenosis. Yeah, then right side was normal. Okay, now what do you do in this case? What would be the diagnosis here? The cause of renal artery stenosis, 22-year-old female. No bleeding, nothing. I did put in a stent, but I feel guilty sometimes whether it was right to have put in a stent. That is why I tried to ask Dr. Rajputkar.
Well, as far as the cause of the stenosis is concerned, in very young women, before doing any intervention, I would have done their CRP, I would have done their ESR, look for any evidence of tuberculosis, also looked at the aortogram. And if I found those abnormal, I would have given it at least a 6 weeks therapy with steroid, looking at the situation, and then come back in to see. Unless, of course, I'm in a situation where the kidney function is compromised acutely and you have got bilateral, or in a single kidney a critical lesion, in which case I would intervene early. Now, I'll start with a very strong clinical indication. Patients, I mean, I have similar patients who had hypertensive encephalopathy before coming, who had flash pulmonary edemas before coming. And so if there was a critical stenosis and I worry whether it will thrombose out because it is in a single kidney, the other kidney being very small, got closed off some other time, then in that case, I wouldn't wait. I would intervene first, look at all the inflammatory markers, rule out as far as possible tuberculosis. And then if there is tuberculosis, start treating that along with small dose of steroid, but otherwise only steroid. People have used azathioprine and others, but I have not done that. I've seen a patient who completely regressed the stenosis when there was bilateral 90% after 6 weeks of steroid. We thought that we will give steroid for 6 weeks and then come back and do the plasty. So when I did the second angiogram, those stenosis had completely disappeared. So it is very important that inflammatory markers should be checked, particularly young women. Now, for a disease which has gone on for long, where other collaterals have developed, and you got bilateral renal artery plus both common iliacs, a left subclavian, that kind of an advanced disease with renal artery filling only through distally through collaterals, surgical option is probably better rather than there. So on occasions, what we have done is auto transplant if the iliac vessels are spared, or a linorenal if the celiac axis is good on the left side, or putting in an arterial free graft from aorta to the distal renal artery on the right side. About a half a dozen such cases.
Thank you, sir. This is a great learning that 90% stenosis can reverse also with correct diagnosis. And
yeah, if you want, I'll share the pictures.
Yeah.
Some other.
Right. I mean,
the other point, Bala, if you have arteritis, quite often you get involvement of the arch, and as Dr. Rajputkar mentioned, you could have subclavian disease. And when I was in India in the government hospital, we have seen patients with almost a bald aortic arch, the stenosis of all the major branches. And if you are not aware of that, the problem is the hypertension which you are treating or the blood pressure which you are checking might be very misleading.
Yes.
So it's very important to have a whole vascular screen in terms of at least a duplex scan to check the flow in the subclavian axillary arteries. And in India, when I worked in MMC, they used to treat patients with steroids, like Dr. Ashpas said, before we treat the patients. And if the patients can afford and if there is time to deal, if you do a PET scan, then you will see the aorta lighting up with the inflammatory signals. And that will be another way of confirming the diagnosis. The most important thing is if they have ongoing inflammatory pathology at a young age, the whole picture has to be kept in the back of mind. Otherwise, the long-term complications might be significant from other parts of the body.
Right. This is another case, 35-year-old male, and again, tight stenosis left renal artery near the ostium. And on the right side it was even funnier. You see, he had two, the early branching, or I think two separate vessels rising close from the aorta. The lower one supplying the upper pole, which was again narrow, but at least it was okay. The upper vessel was very narrow and it was supplying the lower pole. And such a long stenosed segment, what could have been the cause?
Well, again, it is not very easy to say, but the way in which your vessels look, there are multiple stenosis even in the draining vessels. So maybe you should have considered polyarteritis nodosa here and look for other things. Was there any urinary deposits? What was the ESR like? Creatinine and so on. And what's the status on the other side? Now, because if you look at the branches of the renal artery which are supplying the parenchyma, again, there are multiple regions. Now, this sort of a picture you would see, say, in a chronic transplant rejection kind of a situation. In a native kidney, I would have certainly thought of polyarteritis as one of the possibilities and look for other vessels that are involved.
Right. And would we intervene here for the vessels?
I am not sure whether it will be very helpful. What would be the RI of this patient? If the RIs are more than 0.8 and the clinical indication is not very, very strong, I wouldn't intervene. Just do conservative.
Right. Yeah, then there was another case. What happened? Yeah. The whole exercise I started because there was another man, again, this borderline age, 30 to 40 years, and bilateral renal artery stenosis. And the etiology was obscure like this. I put in bilateral stents. It was 3 years ago. Now he has come back with rising creatinine. I did a re-angiogram a few days ago, and I find instant stenosis on both sides, but not critical. I find the 50% on either side, but perfusion is good on both in both the kidneys. My apprehension or problem in my mind is whether putting in a stent in a case of FMD or FMD is can it be detrimental? Or just putting in a balloon would have been better off in that person. So that question came to my mind, and I thought I'll share it and ask you. Or in other words, is putting a stent inappropriately in a case of FMD can lead to problems? Or is instant stenosis is more common?
You're assuming that it is FMD. I'm not so sure about it, number one. Number two is instant stenosis would happen in about 10 to 15% if you follow them long enough. Some patients tend to have it more often. The alternative is, if they show clinical signs of renovascular hypertension, like difficult to control blood pressure, worsening of kidney function on use of ARBs, you're getting flash pulmonary edemas, and if your RI in the peripheral vessels is not very high, then you have indication for re-intervention. Now you can have two considerations. One is if the patient is not very high risk for surgery, maybe consider surgical treatment. And if you have to redo the thing, your chances of getting restenosis are also high. People have tried drug-coated balloons, drug-coated stent within the stent. Nothing gives you very great long-term patency in those patients who stenose within the first couple of years of stenting. There are others who go on for long time without any restenosis, but about 10 to 15% restenosis you are going to get, whatever the cause you put in, because you do injure the intima, and there will be intimal proliferation, local growth factor release, and so on. And if you have strong clinical physiological indicator that it is physiologically strong, significant renal artery stenosis, you may have to re-intervene, and you have got the same choices like you had it the first time. You could use surgery, you could use percutaneous procedure, you can put a stent in stent, a longer one, a drug-eluting one, or a drug-eluting balloon. In renal artery, there are not too many publications about it, to my mind, when it comes to restenosis and its intervention.
It's not that common because of the bigger stent and.
No, but I have seen restenosis, and we have done this repeat stent, but those who stenose, they stenose again.
Okay.
And it's a better idea to involve a surgeon and put a bypass graft, which has a longer term patency, better than the plastic.
Thank you, sir. The purpose of bringing out these cases is not only to clear some of the doubts in my mind, but to tell the juniors that I picked up all these cases just because I was doing Doppler myself. So I think that message is more important than.
I would slightly like to modify your statement by saying that when you are dealing with patients with hypertension, young or otherwise, remember renal artery could be a cause. And then you must look for possible indicators towards renal artery stenosis being physiologically important. Like I said, that you have got difficult to control blood pressure, you've got grade 3 in the fundus, you have flash pulmonary edema without clearly discernible cardiac cause, your patient's GFR worsens with ASARB in an acute thing. If you have all these possibilities and then a non-invasive method like a Doppler telling you that there is good chance of a high grade stenosis. By high grade, I mean above a 70% at least, more like 85, 90% stenosis. That's when I would intervene. Without that clinical background, you're likely to do stenosis just because you see it on ultrasound. Like in the past, cardiologists would, while coming down from the coronary artery, would shoot a aortogram, see a renal artery stenosis, put in a stent, did no good to the patients at all. So you must start with a basic clinical indication, supplement it with a non-invasive method of diagnosis. Look at the patient in general, whether the patient has other arterial beds having clear-cut indication of atherosclerosis, like say having peripheral. And in our country, chewing tobacco is probably as bad as smoking. Now, there are many areas in the country where people chew a lot of tobacco and they do get atherosclerotic disease at a very, very young age. Also, young diabetics tend to get that. So in our series of about 200 odd patients, I don't exactly remember the final number, about 70% of these had tobacco chewing or smoking history. So I would start not with just because I have got a Doppler finding or just because I've got an angiograph finding. I would begin with a specific clinical indicator, supplement it with a non-invasive test. If both these say that I have a high-grade stenosis, which might be physiologically important, then I will take up the patient for an angiogram only if the patient is willing to undergo plasty at the same time. Because if you're not willing to undergo the plasty at the same time, when you actually take him up for plasty or he wants to go to somewhere else, then they will put in the same amount of contrast, to which I'm a bit more worried than the arterial puncture itself. So this is what I practice.
Right. Thank you, sir.
Any stent in any artery will lead to restenosis if you wait long enough.
Yes.
And in the Western literature, many other patients who would have been treated with the renal angioplasty and stenting will be elderly, atherosclerotic, diabetic, heavily calcified arteries. And many of them will not survive more than 5-10 years time in the normal course of life because they will be elderly with multiple comorbidities. But the type of patients whom you are treating are much different, and you have to look at the local Indian experience to see how they respond. And if you have a stenosis which responds well to angioplasty, particularly in these young patients, it may be safer to treat them just with the balloon angioplasty. And if you can use a drug-coated balloon at the same time as you do the angioplasty, that might help, because it will theoretically, the recent literature suggests that it will prevent the restenosis longer compared to non-drug-coated balloon. And if you use a stenting, again, as Dr. Rajkumar mentioned, you can use the drug-eluting stents if they are available. And there is some suggestion that if you use the covered stent, it's less likely to restenose. But the disadvantage obviously is the cost.
Yes.
And the covered stent come with the balloon expandable stent. So the advantage of a covered stent is if you have a very tight stenosis where you are worried about rupture, then you can boldly use that. So it can be used to very confidently stretch.
I use that in transplant renal artery. Okay.
Right. Thank you, sir. I think we had a very fruitful session today. And I thank all the faculty, the chairpersons, and everybody who joined the meeting today. And I think we'll close the meeting today.
Thank you for involving.
Thanks.
Right.
Thanks.
Thank you. Good night, everyone.
Good night. Good
Good
night.
night. Thank you, Audrey.
Thank you.
Okay.
Thank you, sir. Thank you very much for your time, sir.
Right.